you guys for having me. I'm really excited to be here and to be able to present the Flatiron team to you. So we will have three speakers from Flatiron. The first is Tim Showalter, who's a radiation oncologist and clinical researcher who serves as the medical director at Flatiron Health, where he focuses on collaborative research with academic partners, leveraging real-world evidence to accelerate progress of cancer treatment and improve patient outcomes. He also maintains a clinical practice at the University of Virginia, and prior to joining Flatiron was a professor and medical director of radiation oncology at the University of Virginia. His academic research focuses on clinical trials, outcomes and comparative effectiveness, and generating evidence needed to inform cancer treatment decisions. Second, we have Gregory Calip, who is a cancer epidemiologist. He serves as a senior quantitative scientist and quantitative science head for medical and scientific affairs at Flatiron. He also focuses on the academic partnerships and leveraging real-world data, particularly for health disparities in COVID-19 research. He's a clinical pharmacist by training and received his MPH in biostatistics at New York University and his PhD in epidemiology from the University of Washington. He completed postdoctoral training at Fred Hutch in Seattle, and then prior to joining Flatiron, he was an associate professor at the University of Illinois in Chicago, where he had NIH-funded research focused on disparities in multiple myeloma outcomes. And he continues to serve on multiple NIH study sections. Jess Tyus is the director of Administrative and Health System Partnership at Flatiron Health. And she is really the glue that holds this relationship together and works with us on the collaboration for all the different academic medical centers participating in the Flatiron network to support their research interests and value-based care goals. And prior to joining Flatiron, she worked in healthcare consulting, focused on consumer strategy and applied designs, as well as health education and clinical administration for a nonprofit organization focused on healthcare for the homeless population in New York City. And with that, I will turn it over to the Flatiron team.
Perfect. Thank you so much for the warm introduction, and thank you to everyone for having us on this call. We're very excited to present to you. But we want to first just set some context, provide a high-level overview of the Flatiron and UAB partnership. And then we really wanted to spend most of the time focused on research using Flatiron data. We'll do a little bit of an overview of the type of data that is in our data sets, and then really do a deep dive into one of our multiple myeloma projects. And then we'll close out with how to access and how you can use the Flatiron database for your own research. So with that, I will turn it over to Tim.
Great, thank you. So yeah, I'm very excited to give you an overview of Flatiron Health's data and the relationship, and then once we've covered some of the basics, I'll pass it off to Greg to give a deep dive. So, Flatiron is a mission-driven company. The goal is to learn from every cancer patient. So, core to the mission is to learning from all cancer patients, not just the small percent who are enrolled in clinical trials. Go to the next slide, please. So the network is broad. So there are nearly 3 million cancer patients represented in the Flatiron data. The sources are pretty broad. There are over 2,600 clinicians represented in the network whose clinical encounters and tests and other data that have been ordered on their patients are fed into the data. It's an EHR-derived system stemming from 280 cancer clinics, 7 academic medical centers and growing, for a total of 800 unique sites of care. Let's go to the next slide. So the strength of Flatiron data is really in this process. So as I mentioned, it comes from electronic health records and combines both structured and unstructured data. So the structured data, as you can imagine, as being familiar with electronic health records, it's diagnoses, visit dates, and basic demographics, medication orders, laboratory orders, and then importantly, and I think this is where the real value is unstructured data. So as you all know, it's a mess of data that comes through in medical records. We have to process clinically, pathology reports, discharge notes, all these text documents, but Flatiron does a lot of work to synthesize data from both of these sources to create real-world evidence database that can then be accessed for quality and research purposes. So these are packaged in a total of 21 disease-specific longitudinal data sets, and these are called EDMs, or enhanced data marts. And these, each of these cohorts represents patients from multiple cancer care locations and includes abstracted and enhanced data variables in addition to structured data. One unique characteristic about Flatiron is the focus on recency. So there's a 30-day recency for the delivered product. So if you get a data cut from a disease-specific cohort, it's includes follow-up as recent as 30 days prior. The commonly asked research questions. So there's a proposal process for academic partner sites that is on a monthly basis, and there are additional requests for proposal that come. The review process is focused on feasibility and ensuring that the research proposal will ultimately result in a successfully executed research project that satisfies the specified aims. The applications are pretty broad. Of course, patterns of care and outcomes in a real-world setting are a common focus, and other studies just focus on comparative effectiveness research, quality measurement, so adherence to national guidelines or other quality metrics, predictive biomarkers. So the data delivery models also include biomarker information, risk modeling, end-of-life care, which often has a quality focus as well in those studies, and we've got a strong interest in healthcare disparities as well. So the overall partnership, so for UAB's partnership, there are two components in the way we view both the benefits of Flatiron data as well as the structure of the collaboration between UAB and Flatiron, is that there's a dual focus. So there's a focus on quality improvement, and Flatiron produces software and service products that focus on quality improvement use cases. So Flatiron Measure and Signal are two examples that can be used at the institutional level to evaluate adherence to quality measures and to track those in sort of a dashboard format. Today, how we're going to focus on the research component of this. So one of the valuable aspects of a collaboration between Flatiron and UAB is that the investigators at the site can submit research proposals to leverage the real-world data to answer oncology-specific research questions. So just some general data overview before passing it off to Greg for a deep dive. So I want to cover specifically the endpoints and some of the work that Flatiron has done in the way that the real-world endpoints are composed. So as many folks may know, there are limitations to both the Social Security Death Index and the National Death Index. The SSDI is updated relatively frequently, and it's easy to access, but there's a high rate of missingness for mortality events. In terms of the National Death Index, it on the other hand is pretty complete, but there can be some substantial delays in the availability of mortality events. So go to the next slide, please. So what the Flatiron approach to the real world mortality endpoint is to merge three sources. So there's a separate commercial death registry, essentially, that pulls data from obituaries, as well as the Social Security Death Index and the National Death Index for a composite mortality endpoint. And so this is the overall approach that sort of spans across all of the disease cohorts to deliver a composite mortality variable that has the lowest rate of missingness possible. The other variables that we have are real world progression and real world response, which may vary from disease site to disease site. In foundational work to develop the real world progression endpoint, Flatiron compared a radiology anchored versus clinician anchored approach. And so radiology anchored would be primarily looking at the report associated with imaging scans with the idea of anchoring real world progression based on that. And based on the initial work that was done, the clinician anchored approach is the strategy that Flatiron has adopted across the disease cohorts and the data products. And so this is really based on the clinician's interpretation of the entire patient chart. So it includes the assessment of the radiology report as well as clinical information, and is anchored most with clinical practice decisions. And this is the approach that's used for Flatiron data. And then this is just to show that all of these real world endpoints are correlated with overall survival. So what's shown on this graph here is for advanced non-small cell lung cancer. This paper was published in JCO in 2019. And it shows for the same cohort of advanced non-small cell lung cancer patients that progression-free survival, as well as time to progression and time to next treatment, are all correlated consistently and sort of logically with overall survival as well. So I'm now going to pass it to Greg to give more of a deep dive for a specific example from multiple myeloma.
Great, thanks, Tim. It's lovely to meet everybody and be with you here today and join the UAB seminar in the Department of Epidemiology. Wonderful to meet everybody. So I'm going to be talking about a particular study that and some preliminary results from a multiple myeloma study that we submitted to ASCO for this year. For those that are not so familiar, the story of multiple myeloma as it is right now is an interesting one. It's long and with a lot of twists and turns. What feels like 2 lifetimes ago, when I was a clinical pharmacist working in a bone marrow transplant unit, I can think of a time when we mostly treated multiple myeloma with really high dose chemotherapy, and things like bone marrow transplant were experimental. And now really thinking of that as the standard of care, things have really come a long way, and the understanding of multiple myeloma has really progressed. So multiple myeloma is a malignancy of terminally differentiated plasma cells. You can see in this image right here, these are numerous malignant plasma cells that are highlighted in purple. You should know that myeloma is a relatively rare cancer. Only about 1.8% of all cancers are multiple myeloma, but the incidence of myeloma is double in Black or African American patients. Myeloma is characterized by the secretion of clonal immune globulin, which may precede the pathologic diagnosis of MGUS, or a precursor myeloma state. It's something that we understand better and we know precedes most active myeloma, but the actual process itself still has some gaps in knowledge. Historically, clinically characterized, myeloma presents with anemia, bone disease, hypercalcemia, renal impairment, and many patients present in this manner, many with hypertensive crisis or renal failure. More than half of patients present with skeletal bone disease that looks like pathologic or vertebral fracture requiring surgery or radiation to the bone. So folks diagnosed with multiple myeloma are pretty sick when we finally do diagnose them. And biologically, we've learned that the disease is characterized by an intense genomic instability and also dependence on interaction with the bone marrow microenvironment and immune dysfunction, some of which we're going to be talking about today. So as we point out here, the overall incidence of multiple myeloma is rather low. Overall, it's about twice that, comparing non-Hispanic white patients to non-Hispanic Black patients, and about 3 times that of Asian and Pacific Islander patients among non-Hispanic Black patients. So myeloma itself, although sometimes we see that relative survival is similar between groups, there's still space here where we can observe health disparities. And so genetic epidemiologists and health disparities research kind of converge in this space to try to understand myeloma in this respect. On the next slide, we see the death rates corresponding with those higher incidences, the highest death rates occurring among non-Hispanic Black patients, the lowest among Asian and Pacific Islander patients. And these are data from the National Center for Health Statistics and the Centers for Disease Control and Prevention. The takeaway from myeloma over the course of these many years and over the little span of time that I've been studying multiple myeloma is one where there's been serious improvement in survival. This is multifactorial. There have been improvements in diagnostics and treatment for sure. And in 2021, more than half of patients that are diagnosed with multiple myeloma will live at least 5 to 10 years or longer. So, like I mentioned, there have been changes in diagnostic criteria, improved disease monitoring and imaging techniques. Things like bone marrow transplant and autologous stem cell transplant in myeloma are really a standard of care now. Other types of improved supportive care are in place. So antiviral prophylaxis and other antimicrobial prophylaxis, treatment for bone and bone-directed therapy are all kind of standard of care now. However, as you can see here on the right in these figures, only about 14% of patients that are treated for myeloma are ultimately fully cured. So at some point at time in the future, maybe 10 or 20 years down the line, multiple myeloma will indeed recur. And therefore, there's still a wide space for novel agent therapeutics to come into the picture, which is still happening. And this is really an exciting time for multiple myeloma. So getting to what we're going to be talking about today in the study we're describing, the clinical heterogeneity of myeloma has really long been appreciated, as it is clear there is a broad range of disease behavior, with some patients having indolent disease and others having very aggressive disease. As a result, there has been significant interest in developing risk stratification systems that classify patients into different risk groups, thus providing some information about prognosis and potentially inform treatment decisions. Historically, staging systems were based on factors related to tumor burden primarily. However, it's increasingly evident that the underlying disease biology is a key modulator of risk. Also, our ability to detect disturbances in the myeloma genome has changed dramatically over time. So at the lowest level, metaphase karyotyping represents our lowest power of magnification, looking at risk stratification. So these studies have led to the recognition that in general, hyperdiploidy involving odd-numbered chromosomes is associated with lower risk disease, while high-risk disease can involve translocations of chromosome 14, monosomy 13, and monosomy 17. Use of fluorescent in situ hybridization, or FISH, allows for a slightly higher power of magnification and identification of more subtle chromosomal abnormalities considered to be high risk. These are ones that we're going to be talking about today, which include translocation 414, deletion 17p, and gain of 1q, among others. Next, gene expression profiling studies utilizing small panels of genes further enable classifying patients into different risk categories, although studies in this space are still early and there's been shown little concordance between panels used in different studies. And lastly, the advent of deep whole genome sequencing technology has facilitated a much more high-powered view of the myeloma genome, which is beyond the scope of this analysis here, but it's actually an exciting part of another offering that we have piloting with our UAB partnership, the Flatiron CGDB, or clinical genomic database that's really exciting and is starting to roll out soon. So here we come to the challenges. Like we said before, most multiple myeloma is going to recur, about 85% of it, so a large majority of multiple myeloma patients will eventually recur and need to have some type of relapse treatment. There is a fairly poor ability to predict high-risk disease, despite these multiple different mechanisms to risk stratify and stage multiple myeloma. And so far, prognostic markers that we do have in place don't reflect the impact of the microenvironment and are not predictive biomarkers of response to therapy. So these are major gaps still in our understanding of multiple myeloma and a real challenge. And lastly, as we'll describe here, the advances that have been made in multiple myeloma treatment, diagnostics, and screening and prediction have not improved outcomes in all patients. So last year, there was actually a study published by Smith-Geary, who used to be at Yale and is now here at UAB in Blood Advances, that was looking at chromosome 1 abnormalities and survival of patients with multiple myeloma in the era of novel agents. So just within the last 10 years. This was an interesting study. As you can see in one of the previous slides, one of the high-risk chromosome abnormalities was a gain of 1q21. But this study by Smith, Geary, and other colleagues independently associated any chromosome 1 abnormality with worse overall survival, as well as older age, higher ISS stage, other high-risk chromosome abnormalities, and IgA isotypes. But this made a lot of sense in that folks, when you look at a genomic scar score or whole genome sequencing, actually folks that have gain 1q21 or deletion 1p have a higher frequency of other types of genomic abnormalities. So really leaving open the door possibility that there's really yet to be recognized abnormalities that are high risk, maybe for particular subgroups. And this one just in particular highlighted that among the high-risk chromosome abnormalities. The study that we're going to be describing today kind of builds on that work. The objective of this work was to look at racial differences in the impact of high-risk chromosome abnormalities on overall and progression-free survival in multiple myeloma. And we worked on this study with a lot of folks within Flatiron, those from the University of Chicago and University of Illinois at Chicago, and one of our academic partners at Yale School of Medicine. So again, our objective here was to determine the association between prevalence of high-risk chromosome abnormalities and risks of progression-free survival and overall survival among multiple myeloma patients by racial group. For the purposes of time today, we're going to be focusing on progression-free survival specifically and telling that story. And our hypothesis going in was that associations between prevalence of high-risk chromosome abnormalities, or HRCAs, and outcomes of progression-free survival and overall survival differed between Black and white patients. In other words, the prevalence of HRCA is going to be predictive of greater risk of mortality and progression in some patients versus others. In this case, we hypothesized that there would be a greater predictive ability among white patients compared to other non-white patients with multiple myeloma. So using the Flatiron national data that our academic partners also use, this was a retrospective cohort study that we conducted of female or male multiple myeloma patients that were ages 18 years and older. These were patients that were initiating a first line of therapy, which was also their index date. And these were also patients that within a certain time window, 30 days before initiation of a line of therapy and within 3 months after, received FISH testing so that we could have a genomic profile of these patients. Patients were excluded if they had no primary cancer-directed therapy. Some other exclusions that were applied was what if patients had a gap between multiple myeloma diagnosis and any activity greater than 90 days. If you become a user of our Flatiron data, this is called the 90-day gap rule, basically ensuring that we have enough sufficient follow-up to follow patients in the Flatiron data for outcomes and measure covariates. And lastly, in order to abstract information from Flatiron data on progression-free survival, a sufficient amount of lab data needs to be available, specifically electrophoresis of the serum or urine or free light chains, kappa or lambda. So a minimum amount of information had to be available for patients there. But with those exclusion criteria still applied, we still had a relatively healthy size cohort. We looked at patients that were observed between January 2011 to June 2020 with index of line of therapy start dates through February 2020. Some thinking went around that in general, that the pandemic started in February 2020, and we, at the time of doing this analysis, still didn't know what the impact of COVID-19 was on our data. But in generally, our data have about a 30-day recency in terms of follow-up. So the most recent cut of data, which will ultimately kind of refresh these analyses, have data at this point up to the end of February 2021. So from the Flatiron national data, we collected information on demographic and clinical characteristics, including ISS stage, ECOG performance status, and age, sex, race, region, and academic or community practice. We also had laboratory data and genetic testing information on metaphase karyotyping and FISH, as well as M protein and type of light chain myeloma. We also recorded information on treatments, starting with the first line of therapy and subsequently with time varying information on autologous stem cell transplant. So we had information on individual treatments that were given, In this case, we kind of characterize them as doublet or triplet therapy or chemotherapy only for the purpose of this study. So in terms of our statistical analysis, and for the purpose of this presentation, we're gonna be talking about real-world progression-free survival. Patients were followed from the time that they initiated first-line treatment until the event of interest, which was either progression or death, or the end of the study period, which was in which was June 2020 for this particular cut of data. We compared using Kaplan-Meier product limit estimator and log rank tests for equality of survivor functions, and all tests were two-sided with an alpha value of 0.05. We modeled survival using multivariable Cox proportional hazards models, and the primary exposure of interest was the number of HRCAs, so a reference category of 0 by comparing 1 or 2 or more to 0 as the reference, basically looking at double hit myeloma or more as the main exposure of interest here. And we further adjusted for age, sex, type of M protein, first-line treatment regimen, and autologous stem cell transplantation as a unidirectional time-varying covariate. In sensitivity analyses, we adjusted further for staging, ECOG performance status, and karyotype ploidy, which you may ask why. These couple variables tend to have a little bit higher degree of missingness, somewhere between 20 and 30%. So it was really only in sensitivity analyses that these were included to determine if they changed our findings. We evaluated the proportionality assumption using scaled Schoenfeld residuals. And again, with the main outcome of interest of progression-free survival, the event of interest was either disease progression or death. The index time, which was treatment initiation, followed until the earliest of progression, death, or the end of the study period. And we also censored patients whenever their last clinic date occurred, if they did not have an event of interest. So what were our preliminary findings? So after the inclusion and exclusion criteria, we included one of the largest cohorts reported on this so far, over 2,400 multiple myeloma patients that were initiating treatment between January 2011 and February 2020. About 19% of the patients were Black and 81% were white, with median ages of 66 and 69 respectively. And compared to white patients, Black patients had a higher proportion of IgG-M protein and hyperdiploidy, which are both characteristics that were indicative of maybe a lower risk multiple myeloma, at least in this context. A lower proportion of Black patients had at least one HRCA that were identified. So it was like 46% versus 50% among white patients. And fewer Black patients received doublet therapy, slightly fewer, 43% versus 46%, and fewer patients received autologous stem cell transplant. So these kind of disparities in terms of treatment are consistent with other studies and also kind of reflect what our community practice looks like as well too. About 90% of the patients that were included in the study were from community settings versus 10% from our academic sites. On this next table, this is the prevalence of chromosome abnormalities that was observed among Black and white patients in our cohort. As you can see, there were slight differences in gain of 1q, deletion 17p, and overall there was a slight difference in the number of patients that had at least one high-risk chromosome abnormality. Overall, given the large sample size that's comparing between these cohorts, some of these were statistically significant, but in terms of the main differences here, the prevalence looked somewhat similar. You'll notice that some cells here are censored for being less than 5, where for patient confidentiality, we don't reveal cells lower than a certain size. So our main outcome of interest was progression-free survival, and we determined this in Cox proportional hazard models by race, separately for white and Black patients. And the hazard ratio associated with double hit myeloma or greater compared to having no high-risk chromosome abnormalities among Black patients was a hazard ratio of 1.77, which was statistically significant. Similarly, among white patients, there was a hazard ratio associated with double hit myeloma or greater of 1.93, which was also statistically significant. So these were similarly predictive across both Black and white patients in terms of the predictive value of HRCAs in determining adverse outcomes, specifically progression-free survival in multiple myeloma following initiation of first-line therapy. In one of our stratified analyses, which is on the next slide, we looked at this separated out by ages less than 65 and over 65. As you remember from one of our first slides, the median age at multiple myeloma treatment initiation was about 66 years for Black patients. So about just over half of Black patients were under age 65, were over age 65. And when we looked at this, Black patients in this subset, ages 65 years and older, having double hit myeloma was actually not associated with increased risk of progression. There was a hazard ratio of 1.05, whereas among white patients, HRCAs in this group, ages 65 and older, still had a similarly predictive effect of HRCAs with double hit myeloma, having an associated hazard ratio of 1.67, which was statistically significant. So these differences in terms of race stratified analyses are not necessarily practice changing, but really reveal a couple of things that are important. Something to keep in mind when interpreting these findings are that in most clinical studies in multiple myeloma, race stratified analyses almost are just not performed. In some of the very recent multiple myeloma trials, like the Myeloma 9 trial, there were only about 3% that were Black patients, or race is not recorded at all. This wasn't entirely consistent with some other observational studies in this space, even those in the United States. So there's another observational cohort study that's done by the Multiple Myeloma Research Foundation called the COMPASS cohort, where they actually found nothing, there was no predictive ability of HRCAs in Black patients compared to white patients when looking at overall survival or progression-free survival. We found something slightly different, but it was actually only in older Black patients where we found a complete lack of predictive ability of HRCAs to determine outcomes in progression-free survival. What happens here too is this further substantiates the need to really just better understand risk stratification in multiple myeloma. Our understanding, our kind of limited understanding so far of HRCs in myeloma is problematic for a lot of reasons, but the lack of data on non-white multiple myeloma patients stands to really obscure disparities and really prevents disentangling disparities in survival from maybe access to care versus really a biologically aggressive disease that could be understood, with further data available. And this is really at the core of the Flatiron mission, really just trying to understand and learn from the experience of every cancer patient. Our understanding of the myeloma genome through other types of research, including whole genome sequencing, has led to identification of 5 separate mutational processes. One is an AID-APOBEC process, another is somatic hypermutation, others like DNA repair, and processes with unidentified etiology like clock-like signatures often indicate a more high-risk setting. But there's also an age-related process that's is prevalent, and this is often high in hyperdiploid myeloma, so one that we would consider typically low risk. If we think back on what our traditional kind of tumor burden looks like in karyotype, metaphase karyotyping, what that would indicate to us. And so it was interesting to find that among only the older cohort of Black patients where there was little predictive ability, whole genome sequencing might be a way to move forward here and really try to understand what's happening in the myeloma genome. So whether whole genome sequencing and genomic studies such as these that can have data that sufficiently look at different racial ethnic groups, whether this can usher us into an era of precision medicine in myeloma really remains to be determined. We're just not there yet. It's likely that in order to really maximally target myeloma and try to mitigate health disparities in the space, these type of genomics analyses must be coupled with an equally in-depth understanding of the host immune system, environmental factors, and other multiple social determinants of health that also impact cancer outcomes. So what really comes together when I talked about those progress and challenges is really this complex picture and these kind of overlapping types of disparities, and disaggregating those kind of begins with describing them in these kind of studies of Black and white patients treated in community oncology settings. Some of the limitations to our data are really those common to others that we all do in observational studies that use real world data. It's subject to unmeasured or unaccounted for bias and confounding. Like I mentioned before, there can be varying completeness of some key variables, and these are important ones. So ECOG performance status, some particular variables that contribute to staging. We conditioned that all patients had to have FISH testing, but different amounts of patients had metaphase karyotyping that was also done. And only within a certain subset of Flatiron data do we have whole genome sequencing. And not all laboratory data was available on all patients to measure progression-free survival. So that's also one limitation there too, but it was about 80% of the cohort that had full kind of laboratory electrophoresis information and free light chain data to do so. Some other limitations to note, which we are continuously working to improve upon, is the quality of our race ethnicity data that's collected through EHR, which is different from the way we collect it through other types of information like claims data or through cancer registries. And at this point, we have information on insurance and race ethnicity, but not much else at the current moment on other SES variables, but something we're continuing to look at just since they're so important to these kind of questions in particular. And like I mentioned before, this study in particular drew largely from community oncology practices, but depending on the diseases and the different EDMs that Tim mentioned before, this balance tends to vary a little bit, usually skewing heavily toward community oncology, but still with a healthy representation of academic patients as well too. I know we're saving some questions till the end, so I'll kick it back over to Jess to talk about how to access our Flatiron data.
Perfect, thank you, Greg. So just reiterating what Tim said in the beginning, as part of our partnership with UAB, all investigators at UAB have unlimited access to the national data sets on a proposal-based process. And we have a portal called Flatiron Explorer, which is really the one-stop shop for accessing the data, for submitting your proposal, for communicating with Flatiron with any questions, setting up, we have office hours, so you can set up one-on-one meetings with folks like Tim and Greg to talk more about your proposal or to talk more about our feedback. And this is really the place to go. Also within Flatiron Explorer, we have, for each of those disease data sets, we have a specific data dictionary that is tied back to the disease, so you can see exactly which variables are available within and how those are defined within each of the diseases. And we also have some dashboards included that you can start to explore at a high level if your question would be feasible using our data set. So you can filter by certain factors to see exactly how big would that cohort be at the end of the day, and is that sufficient for the question that you're looking to ask. Also within Flatiron Explorer, we have access to our Knowledge Center. Our Knowledge Center is really our database where we try to provide as much information, as much resourcing, as much best practices from what we've learned using our data at Flatiron to you to help you conduct analysis and think about how to best use our data set. And so you can really search within the Knowledge Center by any keyword or any topic that you're looking for and see if there's articles that can help to answer your question. There's also methodology tutorials in there as well that can be leveraged. Also things like the 90-day gap rule that Greg mentioned, how to apply it and why we recommend it is included within the Knowledge Center. And so to access this Knowledge Center, you can email the email that's on here, academic-partnerships@flatiron.com. I'll also drop into the chat a link to a form that you can fill out right now, and then it usually takes us about 3 to 5 days to give you access, and you'll be able to log in and as well as submit questions to us if you have any. So this is really the main place to go. In addition to our kind of recurring proposal process where you can submit as many proposals as you would like, we also, as Tim mentioned, sometimes release certain RFPs. And so one of the RFPs I just wanted to highlight quickly is that we are in the middle of an RFP for COVID-19 focused research specifically. So really the mission of this RFP is to ensure that there's high quality research using our data set and that it's collaborative across our academic institutions. So typically it's not RFP process. You can just submit a proposal at any time that works for you, but we are doing an RFP process specifically for COVID-19 to reduce any overlap, as well as kind of connect folks across our academic network who might be interested in the same questions. This is presentation is a little tight, but basically we're in our second RFP round of submissions right now. We're accepting proposals March 1st through 15th. It's all also through Flatiron Explore where you're able to do that. I will note that our proposal template is not like a grant application or not anything that is 10 pages long of information you have to complete. We try to make it as lightweight as possible while still having the right information to support you and to give you feasibility feedback. But this is something that's happening right now. Additionally, just wanted to highlight that we also are very supportive of our data being used for grants. We're happy to provide letters of support to collaborate with you on your proposal to make sure that you can accurately capture Flatiron data, maybe some of the limitations Greg mentioned. And so that's another area that we're also happy to support folks with.